Okay, so we're looking at the lumbo-pelvic-hip complex today. So that is where your lumbar spine is coming together, right? So the lowest portion of your spine is coming together with your pelvis, right? So that's like your pelvic girdle, but then it's also how it is interacting with your hip joint. So these are technically like different areas, right? You have got your lumbar spine, which comes together with like your sacrum as well. And that's all interacting with like the two sides of your pelvis. That's your pelvic girdle, right? Like this, the left and right pelvis, they are there to act as girdles to hold on your leg bones, right? That femur. And so this is the lumbo-pelvic-hip complex, right? This is your hip joint proper right here. And so that's sort of what we're going to be looking at today. So just so we're kind of going through the intro here, your lumbar spine, right? That is going to be all of these vertebrae at the bottom here, right? That's the portion of your spine referred to often as like the small of your back, right? It's where you get that little arch down there at the bottom section. And then you've got your thoracic vertebrae, which is up here, that middle section. And then you've got your cervical vertebrae up here. And then down below, you do have like your sacrum, which is your tailbone, and your, your sacrum, which is actually what's attaching your two pelvic bones together, and your coccyx, which is sort of your tailbone proper. A lot of people will kind of consider this whole thing one section there, but they are definitely like slight differences there. So most of what we're going to spend our time talking about today is the lumbar spine, your sacrum, your pelvis, and your hip joint. But, you know, all of that is down below where, you know, everything else is sitting on top of that. And so, you know, what goes on down here has a big role to play in affecting things up here. So when you are looking at your pelvic girdle, sometimes you're going to refer to this. Oh, actually, I didn't realize I had little definitions in here, actually. So yeah, your lumbo-pelvic-hip complex, right? Lumbar spine, thoracic spine, pelvic girdle, hip joint. Lumbar spine, right? That's the portion of the small of your back. Thoracic spine, that's your upper back. Pelvic girdle, right? That is, that is your acetabulum. So that's a term that you are going to sometimes see. And that's basically what we refer to as your entire like pelvic girdle. So the two like, you know, two pelvic bones coming together there, that whole area, we call that your acetabulum. Those are your pelvic bones. They're held together with your sacrum in the center that attaches those two, and then your coccyx is at the very bottom there. And then you have your hip joint proper, which is your hip joint proper is also sometimes referred to as your acetabulofemoral joint. Big, long, crazy sounding word, but it's where your acetabulum, the pelvic girdle, comes together with your femur. Here's that hip joint proper, right? Again, it is the articulation between your acetabulum and your femoral head. So that's a ball and socket joint. Just like your shoulder girdle is actually. So, you know, you've got your shoulder girdle that holds your arm on. Well, you get your pelvic girdle that holds your legs on, and both of them are ball and socket joints, which are the most mobile joints in the body, right? Your knee joint from yesterday may be the largest joint in your body, but it is primarily a hinge joint. Whereas a ball and socket joint can do every type of motion we have, right? It can perform flexion, it can perform extension, it can perform abduction, it can perform adduction, external rotation, internal rotation. So because of that, you know, rather than just saying that it can do all of those movements, we have a term that we don't use that often. We really only refer to it when we are talking about ball and socket joints, but it can do what is called circumduction, which is a combination of all of those movements. And the same thing is true of the hips. It's just harder for me to show you on camera. So I'm using my shoulder as the example. Between the lumbo-pelvic-hip complex, you are going to see between 29 and 35 muscles that attach to the lumbar spine or the pelvis. And those are large muscles. We're definitely going to see way, way, way more than that if you get into all of these small intrinsic muscles. So all the little tiny ones that are just there to create like bits of spinal stability. But what we know is that dysfunction in any of the lower extremities or dysfunction in any of the upper extremities can cause lumbo-pelvic-hip problems, right? We can even see when somebody has like shoulder problems, they'll start to kind of baby their shoulder. They'll elevate it like this, and then that causes their weight to shift, and so then that creates like a slight scoliosing of the spine, and so that can affect the lumbar. Work its way down and start affecting the lumbar spine, which can affect the pelvis. Or if you have ankle dysfunction, right, that can travel up and result in hip dysfunction as well. So we're definitely seeing a lot of common injuries here. In fact, the most common injury just in the world in general is going to be general low back pain. And so these are aches or pains in the lower portion of the spine. This affects about 80% of adults. That statistic is true, but it's sort of misrepresented here. When they say that it affects 80% of adults, they don't mean like 80% of people have chronic low back pain right now. What they mean is like 80% of adults will experience chronic, not just like, temporary, low back pain at some point in their lives. So that's, 8 out of 10 people. So more than a third of work-related injuries are often related to the lumbar spine. So a lot of injuries that cost a lot of companies money, which, in the end sort of has an economic burden on all of us, costing about $26 billion every year. And what's funny is like low back pain for the most part should be preventable. It shouldn't be something that like a lot of people deal with. And I say that being someone who struggles with low back pain here and there. I'm unfortunate enough to have like sort of a genetic predisposition for what is called stenosis, which is basically where my spine likes to store extra calcium on all the discs, which means there's not quite as much space between the discs as there really should be. And so lack of space, we know, results in lack of mobility, which is why I often have like a lot of lumbo-pelvic-hip problems. In addition to anything that is like contact injuries. So we definitely know this is a very, very common thing here. And so it's really important for us to make sure that we keep our cores healthy. We want to make sure that we can move our spine around the way it's supposed to. And part of moving your spine the way it is supposed to is part of ensuring that like your pelvic girdle can mobilize the way it is supposed to. And so one of the things that we are often going to see is what is called sacroiliac dysfunction. This is something I've been struggling with a little bit lately. And so this is either too much or too little movement in the sacrum and the pelvis. And so that will often cause a lot of like low back or groin pain. Not any groin pain for me particularly, but definitely a lot of low back pain where I've been getting a pinching sensation on my left side, right here between these two joints, where basically if you look at this little triangular shaped bone, that's your sacrum, essentially like moved it from one side to the other. And so it hasn't been as mobile as it's supposed to be. So my right side is able to rotate and my left side is sort of locked. And so that can be very, very, very painful. And it can cause your hips to become offset. And you can end up with what's called an asymmetric weight shift. And it can cause a temporary scoliosis of your spine. So when we talk about like a scoliosis, right, we mean that that's like a lateral curvature of the spine, right? So let's take a look at what I mean by that, right? So if we look at a scoliosis, you can see there's sort of two different versions here, right? There is sort of what you think of in a natural scoliosis where like it is structural, maybe someone was born that way. But sometimes you can actually develop a scoliosis through like overactive, underactive. That's a really extreme example right there. You can see surgery, they did surgery in order to fix it. But you can see a temporary, what's called functional scoliosis, which is where essentially you develop a scoliosis through overactive, underactive muscles. Oftentimes, you will see a lot of overactivity, which is a great picture. You see a lot of overactivity in these muscles that attach your ribs to your pelvis. And so you'll see overactivity on one side, underactivity in the other. And so that will cause this tilting motion here. And then the upper back will try to compensate and get you back to neutral by going like that. And then you'll end up having this sort of S shape to your spine. You can see that here. We see like rhomboid hypertrophy, trap hypertrophy, and then we see like the deltoid and QL muscles. So we see like overactive down here, overactive down here, underactive up here, and then we cross it in the other direction, overactive here, underactive here. So it creates that sort of lateral movement. One hip either rotating or becoming elevated compared to the other. We will also see very, very common lumbo-pelvic hip problems when we see hamstring, quadriceps, or groin strains. So these are pretty common where people will have like a pretty intense like strain due to like their muscles. Again, if you think of like your pelvis being stuck in like a tilt, right? What that does is that's pulling, muscles like your hamstrings or your hips into an elongated position, and then all of a sudden you try to do like a particular movement, they're already stretched out, and then they end up like straining or pulling, right? So we'll see a lot of like dysfunction in that area as well. And then the most irritating of all of the injuries, what we've sort of been building to, which is a disc herniation or a herniated disc in any of your spinal discs. So looking at spinal disc anatomy here really quick, here is what is called a spinal process. Remember, processes are projections, right? So you see like, you've got the spinal process here, and you'll notice that this is your spinal cord. So like your central nervous system is your brain and your spinal cord, right? So this is like one of the most important key areas in your body. This is what gets, the connection to this is what gets severed when someone, becomes like a paraplegic or paralyzed, right? Basically, they're severing the connection. And so then nervous system signals cannot travel down this cord anymore. But this cord has little branches that branch off from it, and that's where you get all of your peripheral nerves, right? So we can see here's the spinal cord, right? This is part of your central nervous system, and then you can see these little nerve that branches out from here, right? That is your peripheral nervous system branching out individually. And so you can see there's a lot of bone protecting this whole thing, and then we want to make sure that bone doesn't grind on any of the other bones. And so what you have in between are these little discs, right? And so you see is this what's called fibrocartilage here, which is sort of like a lining. It's almost like a thick sac that holds in all of this material in the middle called a nucleus pulposus or nuclear pulposus. And this stuff right here, if you tear this sac, this material here starts leaking out. And when it starts leaking out, it actually pinches on those spinal nerves. And what that does is that sends like a signal, which will often shoot down your leg, or it will, it'll cause like an intense sensation of pain, because, your nerves are designed to, sense information. And if you are poking that nerve, it activates it, right? And that nerve fires. And so you'll get like a pain sensation. It'll activate like pain receptors. So a lot of times with herniated disc, clients will describe numbness, pain, irritation near their spinal discs. And one of the ways you can test for this to tell if you have like a herniation is simple as extending your like hamstring up, so performing like a lot of hip flexion, and then moving your foot up and down like that. And if you start to get like a burning or a numbing sensation, any type of like irritation, it could be because like you have like a herniated disc somewhere in your spine. And so then a doctor would want to take a look at that and look for any specific herniations. By the way, if you've ever heard of like a hernia, just in general, a hernia, what a herniation is in general, guys, like just as a medical term, it is the tearing of like the lining that holds something back and something else leaking through it. So in this case, like we tore the fibrocartilage and this pulposus is leaking out, touching a nerve here. That tearing right there, that's the herniation. If you ever have like an abdominal hernia, it's where you'll actually tear your abdominal wall, and materials from your body will leak through that. Sometimes even like your digestive system in really extreme cases. So that is what here's my advice. Don't look up hernias. It is a horrifying thing to look at. So those are sort of our common injuries. Do you guys have any questions about any of the injuries before we move on to some of the anatomy? Nothing? Okay. So let's go ahead and take a look at some of our bones we'll be talking about here, right? So again, the bones we're talking about before we get into the muscles, we've got your lumbar spine, Thoracic spine will be up here. We've got your sacrum, which is that little triangle shaped bone. You've got both sides of your ilium, which when they come together, we call that your acetabulum, right? That's your pelvic bones. And then we have your femur, right? That's your main thigh bone, and it interacts with the hip bones, right? And so this is your acetabulofemoral joint, aka your hip joint, which is way easier to say, and what I'm going to say for the rest of the day. You've got your sacrum interacting with your ilium here, right? And then you have got your sacrum interacting with the rest of your spine. So looking at that, right? Looking at the hip joint proper, you can see, look at all this connective tissue surrounding it, right? You can't really see it here because they've peeled it all away, but take a look right here. Look at all of these ligaments that are there to hold this joint in place, right? One thing we got to kind of remember about, we kind of need to remember in general about like joints in the body, right? The more movement a joint has, that's great because that means that it's got more mobility and it can do more stuff, but it also means that it has less stability, right? So a mobile joint is a less stable joint. And that's why we see all of these ligaments right here, making sure that we have like as much attachment as possible to keep that leg, you know, attached to the rest of us. So it is the connection between your pelvic girdle, that acetabulum, and the head of your femur. And like I said, it is a ball and socket joint, right? Then we have your sacroiliac joint, right? Your SI joint, as most people are going to call it. And so that is going to be where your sacrum comes together with both sides of your ilium. And so that's your, this would be your left SI joint, and this would be your right SI joint. And so your sacrum is between the two pelvic bones to form that SI joint. And if you lose mobility in here, you know, it is going to be very difficult for your pelvis to rotate, right? Or to elevate or to shift posteriorly and anteriorly. So there is a little bit of movement that is supposed to happen. This, for the most part, is a this is a non-synovial joint, you know, that's there to like be relatively stable, but it is designed to do just a little bit of this, a little bit of this, and a little bit of that. And if you lose that ability, you know, it's only about 2 degrees, but boy, does it make a freaking difference. Any questions about the joints before we get into the muscles? Which structures are like our bones that were there? Any bones or muscles that are confusing? Nope. Okay, so let's look at the hips. So we are looking at, primarily we're gonna look at our movement of the hip today. So, or well, not today, right now. All right, so we're gonna look at hip flexion, hip extension, hip abduction, hip adduction, hip internal rotation, which is this one, and hip external rotation. Wait, no, I did have it backwards. Yeah, sorry, hip external rotation, hip internal rotation. Sorry, I'm like confused myself with my own pantomiming. First one we're going to look at are 4 primary adductor muscles here. Now, again, this is a classic example. This is just like your hamstrings. You're going to see this muscle has sort of 2 separate fibers, but it's technically one muscle, depending on who you ask. So 4 things to memorize, 3 main muscles. And then we've got like your gracilis in there as well. So what we're going to look at first is your adductor longus. Again, it's named after sort of how it looks. It's an adductor muscle, and it happens to be the longest one. So if you take a look here, you can see there's your adductor magnus, there's your adductor magnus again, and there's your adductor brevis, which is a little bit shorter. And so the adductor longus is going to run all the way from, and we're looking at actually the front of the pelvis here, right? We're looking at an anterior view. You can tell because we see the patella. And so this muscle's main job is to concentrically, because you know, always the isolated function is always going to be concentric, accelerate hip adduction, hip flexion, and hip internal rotation. So the adductor longus is primarily in charge of this right here. It is going to adduct, right? So it's going to bring my thigh closer in, or if I bring my knees in like this, right? It is also going to do a little bit of weak hip flexion, so a little bit of like raising my knee up like that, but it also does internal rotation. So again, going back to a client who has knees caving in, right? You look, that's not just like, they're not just caving. I can't just cave my knees in laterally. I've got to adduct and internally rotate. So when we see Knees caving in, which again, one of our most common postural distortions. We know that the adductor longus is one of those fibers that is definitely going to be overactive. So how the heck do we stretch the adductors? Actually, really quickly, I just want to go in a little bit of a weird order. I'll teach you how to stretch it in just a second, but I'm going to skip forward to the adductor brevis here really quick. So I'm going to get to the magnus in just a second. But if we look at the adductor brevis, this is also in charge. This is a little bit of a shorter one, right? But it starts in the same spot. So it originates pretty close, just a little bit superiorly, right? But then it inserts much more superiorly, right? Like it's going to run right to here compared to your adductor. I'm sorry, it's going to run down, where the heck am I? To right here, superiorly, compared to your adductor longus, which ran down here to the mid-thigh, right? So, superior to superior, right? And so that's your adductor brevis there. And its job, you can see identically, is concentrically accelerating hip adduction, so that's the same, hip flexion, that's the same, and hip internal rotation. So both your adductor longus and your adductor magnus, adductor brevis, both basically do the same thing, right? Longus and brevis, basically identical. So you can feel this stretch when you do sort of your traditional adductor stretch, right? So let's go ahead and unfold it, right? We know that, hey, off of there. We know that it's in charge of this, and this, right? The internal rotation. So we basically just have to do the exact opposite of all those things, right? So if that muscle wants to adduct, I will abduct. So I'm going to take a nice wide stance. Then if it wants to hip flex, I'm going to hip extend. So I'm going to drop my leg slightly behind my other one, right? What I like to do is I like to line up my toes on the side that I'm stretching with the heel on the opposite side, although I could go a little bit further if I want to. Now, it likes to internally rotate, so I am not going to do a ton of external rotation because what then will happen is I'll end up like getting into the hip. So what I'm going to do is I'm going to keep it in a neutral position. And then all I'm going to do, I'm going to turn this foot away just to make sure that my knee stays in alignment. I'm going to keep my pelvis facing this way because if I go like this, now I'm just in hip extension, right? So I want to make sure that I'm still in abduction. I got to make sure I square my hips with the direction that I'm facing. So what I'm going to do is I'm just going to lunge away with a nice straight locked leg there. I'm going to keep the weight on the outside of my foot, and I'm going to squeeze my side of my butt here if I can, because the side of my butt, we're going to get into it in a little bit, that's in charge of hip abduction. So by squeezing the antagonist, I'm going to get a slightly deeper stretch. So that's a great way to stretch, and you'll feel it right in that inner thigh over here. That's a really great way to get a hip adductor stretch in, right? And that's really good for the adductor longus, and it's really good for the adductor brevis. Any questions on those two? Because we're about to move into the weird one.
Can you, the brevis and the other, can you point out where they're at?
Yeah, so the longus, right, is here. Yeah, so they're both going to be on your inner thigh, right? So like your longus is going to run from about here to here, and your brevis is going to run from about here to here.
Got it.
They're both going to be starting in the same spot, but they're just right on the inner thigh there.
Do they overlap each other, Brad?
Yeah, the longus is superior, or is superficial, right?
So it's closer to your bone?
Am I wrong? Oh, I think I might be wrong. I think actually the brevis is superficial. I haven't looked at superficial or deep in a while. Let's look them all up.
They're like, but they're like right next to each other, yeah?
Yeah, absolutely. They're nearly identical to each other.
Okay. Oh man, so many terms.
Which one's on top? That honestly does not help much. I need a different one. The superficial deep thing isn't super important because we're not massage therapists. Okay. Okay, no, I had it right. Yeah, the longest is on top.
Got it. Okay, cool.
But again, like here you can see, right? Like they're both running. They're originating in the same spot. They're just inserting in like the longest reaches down longer. That's why it's
Closer to the knee.
right. Whereas the other one reaches down a little shorter. You know, one is further down the thigh and one is closer up the thigh. But
Okay.
they do the same thing. They do the exact same thing. They're both just adductor muscles.
Oh, that's a great picture. Okay, cool. Thank you.
No problem. So then we do have the weird one. Now this is the one that sometimes gets confusing. And I think it gets confusing, especially because again, this is not super well broken down in your book. Um, it's sort of a watered down version. So these are your adductor magnus fibers. Your adductor magnus, take a look at this first one. These are the adductor magnus anterior fibers. Notice how we are looking at the front of the skeleton here. This is attached to essentially the front. So your adductor magnus anterior fibers, they do adduction. I mean, of course they do. They're an adductor muscle, right? So of course they're going to do adduction. But because they're on the front of the hip, they are also going to do hip flexion, and they are also going to do internal rotation. So the adductor magnus also does exactly the same things as your adductor longus and your adductor brevis. All of them, right? All of them do the same thing, which is adduction, hip flexion, and hip internal rotation, right? So, and you can see how wide these fibers are. Now, your adductor magnus posterior fibers, you can see some of them, and the reason these have the reason they have these two different fibers, you're actually looking at the same picture here. You're just looking, here's the front of the skeleton, here's the back of the skeleton, right? You can see the patella. Front, back, front, back, front, back. And you'll notice it originates in the same place, but then it's kind of like a webbing, right? And that webbing sort of twists. Imagine taking like almost like a sheet of paper, and then like, you know, you're gonna twist that sheet of paper, and some of it's gonna attach on the front of something, and because you twisted it, the other half's gonna touch on the back. We're actually gonna see this arrangement again later on when we get to your pectoral muscles. Your pectoral muscles, they actually fan out and then they twist. And before they insert. And you can actually see a much better picture of that. Actually, the pectora are better examples. So if you look at our pectoral, if you look at your pectoralis major, you will notice, where is it? I love these green ones. See how it actually twists, right? The same thing is happening in your adductor magnus posterior. And so when you look at the adductor magnus, God, I know like it's so much easier to look at muscles and they're red and like that jives with our brain so much better, but I freaking love Ken Hub. They do them in green and I just think it's so much easier to see. But you can see like that twisting sensation happening, right? And so some of that's inserting on the front, some of it's inserting on the back. And so they do different things. Oh, that's even better. Look at that. That's a great twist. So you can see the two sort of separate sections of the fibers here, right? So oftentimes there's sort of a nickname in the kinesiology community. Sometimes you will hear people refer to the adductor magnus posterior fibers because it's on the back part of your thigh. Sometimes you'll even hear people call this the fourth hamstring muscle, sort of as a nickname, because it is going to concentrically accelerate hip adduction. So no surprise there, right? It's totally doing the same thing as all of our adductors, right? It's an adductor muscle. Of course, it adducts the thigh. But instead, it is doing hip extension and it's doing hip external rotation. So this hamstring muscle does hip extension. So because of that, if you want to stretch your adductor magnus posterior fibers, you actually need to take your hip into hip flexion, and that will actually stretch it further. And that's why we have a different adductor stretch for this muscle in particular. So if you're trying to stretch your adductors in general, if you have a client whose knees are caving in, they need to do this one, right? They need to do the side lunge. That's how they're going to stretch it. But if you got somebody like me who has sort of a posterior pelvic tilt, right? Somebody who has slightly overactive glutes and slightly overactive hamstring muscles, right? And so you know, instead of having that classic like Instagram booty, I've got old man butt, right? Like the posterior, that is often caused by these adductor magnus posterior fibers. So you have a different adductor stretch here. So what you're going to do is you're actually going to take 1 foot up. Remember, this adductor muscle does hip extension. So in order to stretch it, we need to take it into hip flexion, right? But it is still an adductor muscle, so I don't want to let my knee cave in. So I'm going to push my knee out. And then what I'm going to do is I'm going to anteriorly rotate my pelvis because it wants to unstretch by going like this. So I anteriorly rotate my pelvis. I'm going to bring my hands together and I'm going to lunge down like this while driving my knee away from my midline. And so by stretching like this, I'm going to feel a really deep stretch in the posterior aspect of my thigh and right in my groin, right? So the longest, the longest, the brevis, and then your magnus is like right in the center of your groin. And so that's the one where when you're stretching this, we have 2 different adductor stretches. We have this one here where I'm driving my knee away and I'm performing hip flexion instead of hip extension. All 3 of my other adductor muscles, and I say 3, I technically mean 2, but all of my other adductor muscles, they're hip flexors. So I want to stretch them by taking my thigh backwards. This one I want to stretch by taking my thigh forwards. And that's the most confusing part of the whole day, is these 2 fibers right here. That's the most complicated bit, in my opinion, out of the whole day here. Hopefully I don't eat my words in a little bit, but in my opinion, that's the most technical. Do you guys have any questions about the difference between your adductors?
No questions between them, but well, maybe. What do people say, or what do people mean when they say I pulled my groin?
So a lot of times they're either talking about this adductor mat. You see this like fascia right here? See how like white this section is? Low blood flow. Low blood flow means it repairs really slowly. So a lot of times you're going to see your adductor magnus be a muscle that got pulled. And so basically this tightened up so much, and then they probably did some type of like lateral movement, and all of a sudden, like, you know, the muscle was like, whoa, no, and it just pulled really hard, but then it was too late, too little, too late, and so it basically created like a small pull or a small tear. A pulled groin, a pulled muscle anywhere in the body, like I pulled my hamstring a couple of years back. Basically what that is, that's a tearing of the muscle fibers. And you're gonna have like you'll say like I tore a muscle, I pulled a muscle, right? That's either gonna be referring to like a pull in like the belly of the muscle, or it can happen in like the tendons, right? It can happen anywhere throughout the, like if we look at a pulled muscle, right? What it is basically, yeah, that's a great picture right there. You can see like just a little bit of a tearing, or that, right? That's a pulled muscle. So that it's almost like the difference between, you'll hear people say like a herniated disc or a torn disc in their back or a bulging disc. All of those, same thing. They all mean exactly the same thing. They're like a herniation is causing a leaking, which is causing a bulge, right? So that's what a bulging disc is. I mean, some people will say, you'll hear some people say it's like, no, it's like only slightly pushing through the lining, and it's like, look, it's like the term. Robert, you ever heard somebody say that they have like pre-diabetes, or pre-hypertension? It's like, look, we could classify, you know, a million different levels of things, but it's like you either have diabetes or you don't. Like if you have pre-diabetes, that means that you don't have it, and it is your job now to take steps to not get it. If you have pre-hypertension, like it's not causing you problems, but you're clearly at risk, right? It doesn't mean you have a different version of the disease, if that makes sense. That's the difference between like pulled and torn. But what you'll see in torn muscles, we label them as grade 1, grade 2, or grade 3. Grade 1 is basically what you think of when you think of a strained, like pulled muscle. You know, you've probably done this at the gym a couple times. You've probably like had small pulls, you know, where like you were doing just like a really heavy lift and you're like, yeah, and then your adrenaline's pumping like crazy. And so you leave the gym and you're like, oh man, I crushed it today. And then you wake up the next day and you're like, oh, that's achy. You know, it's like, oh, I need to take it easy for a week or two. That's like a grade 1 pull. It's basically just like a strain. There's some tearing, but it was so minor that like if you were to probably look at it, you probably wouldn't even notice. Grade 2 tears are partial, actual like physical tears within the muscle. And then a grade 3 tear is like, whoa, that is detached. You have torn the muscle in half, you know? And then grade 3 tears usually require like surgical reattachment. This is why, you know, I'm not a huge fan. Here's what I'll say, like, it will work if you do the mixed grip deadlift. You know, underhand over here, overhand over here, that will make your grip so much stronger and it will be way easier to do your deadlift. I promise you. But I don't like it, even though it's effective. And people are like, why? And the reason why is because your arm that is supinated, you are putting an extra stretch on your bicep tendon. And then you are also, you know, the weight is pulling your arm down. So you are then further stretching your bicep tendon. And there are just way too many horror stories on the internet and videos of people like deadlifting super heavy, and all of a sudden you'll see them just go, oh, and they'll just drop the bar. And it's literally because they just ripped their bicep in half. I hate it. I really do not like mixed grip. Anyway, I'm starting to get distracted, but that is what we say when we say like a pull, like a strained groin. It means like it's a grade 1 tear as long as it's not too serious. Does that answer your question? I got so like I went off on my own tangent.
Yeah, and then you would just give it a little SMR to heal it back up, right?
Sort of. I would eventually. Make sure, guys, if you ever have like a tear, we'll talk more about this in the sports class actually, because that's kind of where we look at like temporary injuries. But if you have like a grade 1 tear of something, or especially if it's a grade 2, like go see a doctor. Grade 3, go see a surgeon. But if it's like a grade 1 tear, you really want to leave that muscle alone for a little while, because you got to remember that it's going to go through like a healing process, right? And so what's happening is because you tore the muscle, your muscle is bleeding internally. So just like a cut on your hand, you don't want to like just let it kind of bleed out. You put a little pressure on it until eventually like your body can kind of get to the area and like, you know, create like a platelet plug, right? And like stop that bleeding from happening. Same thing is happening in your leg. So what you want to do is you want to like reduce the bleeding as much as possible. So here's a general rule of thumb to follow whenever you have like a strained muscle or soreness or anything like that. You want to follow what is called the RICE protocol, R-I-C-E. Rest, ice, compress, elevate. So first thing you need to do, leave the muscle alone, rest it, right? Second thing you need to do, try to put a little bit of compression in there. So that's often why you'll wrap it with like an ace bandage or something like that, and that'll sort of limit blood flow for now. Then you want to, ice it first. Went in the wrong order. I forgot how to spell rice. Rest it, ice it. You want to restrict blood flow. So by icing it, that's going to constrict all the blood vessels. So there will be less bleeding that takes place. Compress it in order to like, again, prevent bleeding. And then elevate it, keep it up, try to get it above your heart. So if you sprain an ankle, you know, tear a calf muscle, something like that, lay on the couch, get your leg up. You know, best thing you can do is try to keep it above your heart in the world. And that will sort of keep blood from like flowing in there. You really only want to do that for maybe 24 to 72 hours. You really, like a lot of people will ice for weeks at a time. And it's like, that's not doing anything for you. Now you're preventing healing. You know, the reason we want to ice things and the reason we want to reduce inflammation right away is because like that is going to prevent your body from healing something in its torn, messed up version. You know, we're trying to prevent too much scar tissue from getting formed. So you go through the RICE protocol. Then once it's healed enough, you can start heating the area. So then you're going to switch to heating, and you're going to try to like heat the area up, and then do like, you know, gentle stretches, maybe a little foam rolling, because we don't want scar tissue to form, which will then, you know, if we let scar tissue form, which by the way, is going to look like this. If we look at like scar tissue, Scarlett Johansson, first thing that popped up. Oh, sorry, not scar tissue, muscle. When you look at your scar tissue, it'll kind of look something like this, where your body's like, you know, it basically, you know, covers the whole thing with all this extra tissue, which reduces your mobility. Right now, this is an inflexible muscle. You have what's called an adhesion here. So we want to like keep those adhesions from forming. Or if we already have adhesions, we want to bust up those adhesions with like foam rolling and things like that. And that's why, like, you know, you'll hear me say when you're foam rolling, generally we place a foam roller on, you know, the tendons, right? We place it on like where the Golgi tendon organ is located. That's where we want to put pressure in order to relax the muscle belly. But sometimes you'll also just roll in the middle of the muscle. And when you're rolling in the middle of the muscle, you're basically just trying to bust up some of that scar tissue and kind of get it to go away. You want to see like a brutal technique, guys, that's all about scar tissue. I've never had this done, but it looks absolutely brutal. But it's called the Graston technique. And what it is where basically they will scrape your muscles in order to break up scar tissue. We actually teach this at Sochi. They teach Graston. I think they do actually. But you can see here, this is a Graston. So he's going to use this metal bar here. And, you know, this person's probably got, oh, you can actually see they had surgery on their inner thigh there. Yeah, so this person's had like very clearly like some type of like reconstructive surgery. So there's going to be a ton of scar tissue in here. So they're trying to get this person's mobility back. So they're doing this Graston thing. All right, skipping forward. So they're going to like lube them up like crazy, you know. Can we just get to the freaking... Oh, is he not doing it on the calves? Oh, he's doing it on the foot. Okay. So he's doing plantar fasciitis. And basically just gonna scrape like crazy and try to bust up some of that scar tissue. Oh, here's Brent Brookbush. Here's my guy. All right, we're gonna go to his videos. Here's him doing Graston on like someone's thoraco. I actually could probably use this. This is your thoracolumbar fascia here. And so they're scraping. This is kind of like, is similar to foam rolling, but it's very much just about like scraping things up. Now here's what's kind of crazy, and this is why it's so brutal looking. I'm gonna show you the Graston technique. Here's what your body looks like afterwards. You get a lot of external bruising happening. And it looks pretty rough, but it is actually a very, you know, popular technique that is quite good for you. I know it causes a lot of external bruising, and I know it doesn't look very pleasant, but this is very, oh man, it is actually quite good for you, despite how brutal that looks. It's kind of like cupping. You guys ever see like when people do cupping? I actually don't know if cupping is any actually good for you or not. I think the science on that is out, but it's where they'll basically heat up those cups, and it'll cause like bruising. And you can see like, oh man, holy crap. But there's like, you know, the idea here again is that it will break up scar tissue.
Brett, they don't apply anything on their skin like oil or something? I'm
sure they do. Yeah, I think they do. I'll be honest. I'm not exactly an expert on this, but yeah, they'll apply like a little bit of like, you know, something to get it to, because you know you don't want you don't want to cut the skin.
There. Yeah.
They can apply cocoa butter to it.
Yeah, that makes sense.
Cocoa butter.
But it's brutal, right? Ugh. I honestly, like with all this SI stuff, if I can't get this freaking chiro to get my thing back in place, I might go see someone to Graston my my thoracolumbar fascia, which we are going to see in a few minutes. Actually, we are on our way to that part of our musculature. So that's all good. These are all, by the way, these are all like really great questions because they are totally related to what we're talking about today. But that's sort of what you do with like muscle. That's what a muscle, a torn or a pulled muscle is it's basically just like a small tear. All right, so we've got gracilis here. You'll notice I didn't put I didn't put the info down here because I didn't want anybody to have to like, I don't want anybody to like forget that they already did a muscle and then end up like doubling up. But your gracilis, right? That's that muscle from yesterday. We saw it as a knee stabilizer. It is also accelerating hip adduction, hip flexion, and hip internal rotation. The only thing that it does as well is because it is not just attaching, you know, all of our other adductor muscles were only attached from the hip to the femur. So they were moving like the femur. Your gracilis is attached to your tibia. So it can also do tibial internal rotation. So this acts like a lot of your other adductor muscles, but it can also move the lower portion of the knee around, which is why it's a knee stabilizer. You got one really short one. Robert, this is also very much when you're talking about a groin strain. This is a very, very, very common muscle if it's really, really high up in the groin. Sometimes it could be a strained pectineus, which is this little tiny one at the very top here. And usually that's when people are describing really close to the actual like groin here, very top part of your femur. And so this is a little short muscle. It does hip adduction, right? It's an adductor. It does hip flexion and it does hip internal rotation. So your pectineus is doing all the same stuff there. It's just a much, much, much shorter adductor muscle. So that was your adductor complex. Let's go ahead and take a look at the abductor complex. So now we got to go in the opposite direction, which means we're talking about the moneymaker. We're talking about the king of muscles. We're talking about the glutes. So every trainer's favorite group of muscles, your gluteus muscles, right? I just said gluteus muscles because I was about to joke around and say my favorite Roman soldier, gluteus maximus. So this first one we're looking at is your glute med. And that's, by the way, if I'm going to probably use those terms a lot. I'll say glute max, glute med. I'm talking about the gluteus maximus, gluteus medius. Your gluteus medius has also, similar to your adductors, two sets of fibers. You're going to see some anterior fibers and you're going to see some posterior fibers. And they do ever so slightly different jobs. So your gluteus medius is your side butt, right? It is the middle glute compared to the other two. And so your gluteus medius anterior fibers, which are here on the front, they concentrically accelerate hip abduction. So this is the big muscle that's mostly in charge of this, right? That's your gluteus medius, right? And it also does a little bit of hip internal rotation, but we're not going to give that too much credit because most of the time when we are talking about the gluteus medius, we are talking about your posterior fibers, which you can see are going to run from the top of your pelvis over to the side on that greater trochanter of the femur. And so that knob on the side of your femur, it's going to pull on it, and that's what pulls your leg up like that. That's what does that hip abduction. And this is really the actual, when we're talking about like a weak gluteus medius, we are talking about the gluteus medius posterior fibers. This is an often underactive muscle. When you have a client, again, going back to knees caving in, right? What is knees caving in? It's adduction and internal rotation. So guess what? Your gluteus medius does abduction and external rotation. So this is literally the exact muscle we want to strengthen when we see a client with knees caving in. So concentrically accelerates hip abduction and hip external rotation. So we can strengthen it by going like this and performing external rotation. We can strengthen it mostly by going like this, is the best one, right? Or we can do like side shuffling. We can do resistance bands around the knees, right? Gluteus medius abductors, right? That is the main role of that muscle. So when we have clients whose knees cave in, this is definitely a muscle we want to stretch. So now we know that like we should did I say stretch? I meant strengthen. Now we know that like if my client's knees cave in, I'm going to do that adductor stretch, and then I'm going to follow it up with an abductor strengthening exercise. So that's your side butt. That's the gluteus medius. Then we have your gluteus minimus here, which is just like your gluteus medius anterior fibers. This does a little bit of hip abduction, but it also does internal rotation. So your gluteus minimus is the only butt muscle that we sometimes refer to as a bad guy. This is the only one that sometimes turns against us. And it's because it does hip internal rotation. A lot of times when you see, I forgot this was up. Remember I talked about like knees cave out? Sometimes you'll see clients with knee varus. It's very rare, right? Most of the time we're seeing knee valgus, but every now and then you'll see like bow-legged, right? When you see a client with like bow-legged posture, again, very rare, but usually it's because I can't even find that good of a picture right now. I guess that actually, you know, that kind of works, but that's, again, you can see it's because the bones are. Finding knee varus is super rare because a lot of times you're just looking at rickets. Knee varus athlete. Yeah, see, it's all valgus pictures. Okay. Well, I'll give you a fake demo then. All right. So when you see somebody whose knees cave out, a lot of times they will be sort of pigeon-toed, and they'll be supinated with their feet, and they'll squat kind of like this. They'll have this like really intense bowing sensation where like they're not lining up very well. You'll notice, like, see how like my knees were like trying to cave back in. I'm like resisting this motion. But that is often from an overactive gluteus minimus. This is not going to be in your regular textbook, by the way. You're not going to see any information on knees cave out because it is super rare. But you will see it in the corrective exercise class with Mo. So we just wanted to mention it really quick. So this gluteus minimus does a little bit of internal rotation. It's this inner butt muscle here. It's really near what is called your piriformis, which we're going to see is going to run actually from back here. But sometimes that can get overactive. And then, you know, I wish I had like a sound system where we're gonna play some like hype music right now. We got the main muscle, the best muscle in your body, the one that every trainer wants to spend most of our time working on. It is the largest muscle in your body, and it burns the most calories when you exercise it, the gluteus maximus, right? So this is the overall butt muscle, and this concentrically accelerates hip extension and hip external rotation. So it is working with the gluteus medius to do external rotation, but the medius was performed in the frontal plane. That's doing abduction, right? Your gluteus maximus is in the sagittal plane doing hip extension. It is kicking your leg posteriorly, right? So you can put your hand on your butt and take your hand like this, and you will feel that main butt muscle squeeze. That's your hip extension. So, finally, we can stop talking about knees. I mean, this is still involved with knees caving in. If you got a client with knees caving in, again, they need to do more to strengthen the gluteus maximus. But this is also where we are going to look at another one of our most common postural distortions, Instagram booty, AKA anterior pelvic tilt. So when you see an anterior pelvic tilt, what you are noticing is it is somebody who has rotated their pelvis in this direction. So what is happening there is like the attachment sides, the ASIS over here, right, is being pulled downwards, right? And so it is being pulled inferiorly in the front, which is making the whole pelvis rotate towards the front anteriorly, right? Meanwhile, you've got muscles in the low back that are attached up here, and they are pulling upwards, right? And so by pulling up in the back and down in the front, you create this sort of like stick your butt out Instagram booty posture, right? And that is that anterior pelvic tilt, right? And this is often more commonly referred to as lower crossed syndrome. The reason it's called lower crossed syndrome is because it looks like this. When you look at the, when you look at the overactive muscles versus the underactive muscles, you see a cross. You've got tight overactive muscles in the low back. You got tight overactive muscles in the front of the pelvis. You've got weak abdominal muscles up above, and you've got weak butt muscles in the back. So tight hip flexors, weak glutes. Tight low back, weak abs. And that's what causes anterior pelvic tilt, right? AKA lower crossed syndrome. So this is our most commonly underactive muscle in the body. Like you'll notice if I go to like that NASM PES solutions table, if we look at the overhead solutions table, right, and we look at like knees cave in, underactive muscle, gluteus maximus. We look at excessive forward lean, underactive muscles, gluteus maximus. Low back arch, underactive muscles, gluteus maximus, right? It's just everywhere on this list. All of us need to work the booty. And those are your hip. So now we've looked at our hip adductors and we've looked at our hip abductors. And we got to look into one hip extender as well. Any questions on that, guys?
Yes, Brad.
Mm-hmm.
So the maximus doesn't play a role in the internal rotation, only the minimus.
The minimus and only the minimus. I mean, the medius anterior fibers do a little bit as well, but honestly, Irene, like no one's ever going to ask you about that. Minimus. Keep it simple.
Okay.
I don't even think, honestly, I could be wrong, but I don't even think, and this version with these I don't even think that's in your book, to be honest. I think that it's in this PowerPoint, but I don't think it's in your book. I've looked at that list a million times, and I'm pretty sure that one's missing. So yeah, Maximus does this and this, right? And then it also does external rotation. And then medius does just this and external rotation. And then minimus does internal rotation. I don't know if that was actually helpful. All right, let's start getting into the hip. So now we've looked at hip adduction, we've looked at hip abduction. Now let's look at hip flexion. So we're going to look at this motion here, right? Hip flexion, driving our knees up, AKA sitting, right? I am in a hip flex position. This right here, what I'm doing right now is why my glutes are underactive, right? It's why your glutes are probably underactive. It's why everyone's glutes are underactive and our hip flexors are so tight. You know, depending on what your posture looks like. So first one we're going to look at in your hip flexor complex. And by the way, when I say hip flexor complex, it is a complex. It is several muscles all working together to perform hip flexion. So you can actually see that whole complex right here. Again, some of your adductors are sort of part of it. You've got your psoas up here, which is the first bit where we're starting to get into the spine. And then here's that frickin' TFL muscle, right? This devil's muscle, this weak muscle, muscles of the hip. You know, I'm actually, this is great. Here's your whole hip complex. I'm gonna keep this open. So let's look at the hip flexors. First one we're going to look at is the tensor fascia latae, but we're putting a little asterisk there as well because they are also showing you a picture of the IT band, that iliotibial band, which is a muscle but doesn't really have so much contractile. It's mostly made up of fascia. But the TFL is a muscle, right? So the tensor fascia latae, or tensor fascia latae, if you want to say it that way, and so it concentrically accelerates hip flexion. It also does do a little bit of hip abduction. So in a weird way, your TFL assists in that hip abduction, but this is a classic example of an overactive synergist muscle. So actually, if you guys are at home right now, stand up, stand on one leg, and just give me some leg raises to the side. Now, do you feel that here in the side of your butt, or do you feel it here in the front of your hip?
Front of the hip.
You feel in the hip?
Yeah.
So we don't want to really feel in the hip because that means that the TFL is doing more of the squeezing than the glute is. This is supposed to be a synergist. Your gluteus medius is supposed to be an agonist, right? So this is Robin keeping Batman from doing his job. So, and it's super common. It's super, super, super common. So what we need to do is consciously squeeze the side of our butt, and instead of just raising straight out to the side, take that leg just ever so slightly back, then kick it out. You'll notice you probably won't get quite as much range of motion at first, but you'll feel it more in the butt and you'll feel it less in the hip. Do you feel that? So
Yeah.
you take your leg back a little bit, you squeeze, and you lift from here. That is a cueing technique that we often need to do with our clients, because a lot of times you'll be like, great, we're going to strengthen the side of your butt. And you'll make them do like abductions. And then you're like, so how was your day? And they're like, oh, it was good. And they're working. And to your naked eye, it looks like they're doing everything they're supposed to be doing. But they're feeling it in their hip instead of the side of their butt. Not what we want. So you want to give them a little bit of cueing by saying, like, do you feel that in the side of your butt? And if they say they feel it in their hip, you got to go, okay, pull your leg posteriorly just a little bit. Let's bring it back and then do your kicks. And that's going to make that much more effective, because you are going to deactivate the TFL by performing a little bit of hip extension, because the TFL concentrically accelerates hip flexion, right? It is part of flexing the hip like this. It is a little bit of this, although we're not really writing home about that. And then it is also in charge of hip internal rotation. So it is rotating the hip inward. So that is another very commonly overactive muscle. Apparently this time of year, I just need to do that every day from now on. So because this is such a commonly overactive muscle, I want to show you guys how to stretch it. So again, it does hip flexion. So we are going to perform hip extension in order to stretch it. So what I'm going to do is, instead of letting my leg go forward, I'm going to drop my leg back into hip extension. It's an internal rotator, so I'm going to externally rotate my foot. I'm going to keep my hips square, and I'm going to lunge forward and lean away. And that's going to get into that TFL. You actually don't need to do the upper body lean if you don't want to. You can literally just do, this at first if your client like struggles with their balance. But your weight should be on the outside part of your foot. You want to try to actively squeeze your butt, and that will help you stretch out that TFL muscle. This and the biceps femoris. This guy and that biceps femoris from yesterday, they're the devil's muscles. Now, another part of your hip flexor complex is your psoas, your psoas muscles, okay? So your psoas, which is this group right here, this is actually attached to your spine and attaches to the front of the femur there. So remember when I talked about an excessive forward lean during a squat, and I said that it could be caused from tight calf muscles, and so somebody's just shifting their weight forward because they can't shift their weight back. They have limited dorsiflexion, so they have to lean forward to make up for it. Or sometimes an excessive forward lean, it could be their abs and hips pulling them downwards. These psoas muscles right here are exactly the muscles I'm talking about. So this is another muscle that anteriorly rotates the pelvis, right? And so that's going to cause an anterior rotation here. So it concentrically accelerates hip flexion and hip external rotation, although again, that hip external rotation part, we're not writing home about that. Really what it's famous for is the hip flexion. And it does actually do a little bit of spinal extension. And it also does a little bit of rotational movement. But again, spinal extension, right? Spinal extension is this. Spinal flexion is this. So when we see an anterior pelvic tilt, we see the lower cross syndrome, right? We know that somebody is doing too much extension and too much anterior tilt. So they've got this super intense low back arch. So what muscles are overactive? Definitely the TFL, definitely the psoas, okay? And then you're gonna have your iliacus here, which is running on the inside ridge. So there's actually a view from the front. It's gonna run from the inside ridge. You can actually sometimes feel this, although be gentle, guys. if you kind of dig into your pelvis, and you kind of dig into, like, you can feel that little flare there, and you kind of rub it. Just make sure you're really careful with this. Do not try to push really hard on this muscle right now. Do not, in fact, don't really goof around. I shouldn't even say anything. Don't goof around with this muscle too much. Your appendix is right there. And there are horror stories about people who are like trying to massage their psoas and then they like rupture their appendix. So I take back what I said. Don't touch that. But that's your iliacus, right? It's this muscle right here. It is also concentrically accelerating hip flexion, hip external rotation. So hip flexor, hip flexor, hip flexor. Your sartorius from yesterday in the knee muscle, that is also acting as a hip flexor. And then one of the main ones, that knee muscle we looked at yesterday, is also the rectus femoris, right? So here is the sartorius from yesterday, right? It is running from the hip down to the tibia. And then we see that, where's the rectus femoris? Is it not in the, what? Okay, well, rectus femoris should be in this PowerPoint right here. That rectus femoris is one of the main hip flexors. So in a client who has an anterior pelvic tilt, overactive muscles, tensor fascia latae, psoas, iliacus, and sartorius / rectus femoris. So in order to stretch an anterior pelvic tilt, one thing that we can do is the TFL stretch here in a standing position, but we can also do a kneeling hip flexor stretch where we just take it into a kneel, my leg is behind, and then what I'm gonna do is I'm gonna keep my chest upright and I'm gonna lunge forward. Now, if I wanna make this stretch even deeper, remember, I can always squeeze my glute, right? I can squeeze the antagonist muscle, right? If my hip flexor wants to pull me this way and I squeeze this muscle, which wants me to pull this way, I can get an even deeper stretch out of that front muscle, right? So make sure we are doing that as well. Squeeze the antagonist muscle when you're trying to get a deeper stretch. One little note, I want to give you one more thing, just because I see it's written here, and this is how you're going to see it in your book a lot of times. Because your psoas and your iliacus actually share so much common space, you can see this here. A lot of times these will be referred to as sort of a group together. They're like partners in crime. So they'll sometimes be referred to as your iliopsoas. And that's a combination of your ilium, your iliacus, and your psoas. Questions on the hip flexor complex? Nope.
No, sir.
All right. So let's look at the next one. We are moving forward to the piriformis here. This is another bad guy muscle. And this, here's a little fun fact, is the only deep muscle that we actually foam roll intentionally. So like most of the time when we are foam rolling, we're really only working on the superficial stuff because you really can't get enough pressure on the deep stuff without like deep tissue massage. But your piriformis is a good example. It's slightly exposed right here near your sacrum. So you can get a little pressure on there with like a lacrosse ball or a foam roller. So your piriformis, this is attaching your sacrum to the greater trochanter of the femur right on the inside there. So it's not running over top and attaching here. It's running to the inside here. So when you look at how it pulls, right, it accelerates hip external rotation. So it is pulling externally. And it does do really weak hip abduction and really weak hip extension. But this is a very, very commonly overactive muscle in a lot of clients. And sometimes you will get piriformis syndrome. And what piriformis syndrome is where someone will describe a shooting pain sensation that runs down their leg. It's more commonly referred to as sciatica. So remember, right, your nerves travel out from your central nervous system. So right here, see this little bundle, this junction of like these four fibers here? That is your sciatic nerve. And it runs behind your piriformis. And if this muscle gets super, super tight, it can start poking that sciatic nerve. And so you'll get sciatica, which will cause this pain to run down the leg. So if you ever hear people describe like a burning sensation that travels down their leg, they're like, I don't know why, just it hurts down my leg. I don't really get it. Why does it feel, why do I feel like a burning sensation? It's not like a pulled muscle. It feels, it's your nervous system firing, right? That's what piriformis syndrome is, or sciatica. So how do we loosen that up? Well, we got to stretch that muscle out. So again, it is in charge of hip external rotation, abduction, and extension. So we're actually going to do the opposites of all of those things simultaneously. So we're going to lay on our backs, and we're going to rest one foot up on top of the other. And what I like to do is I like to line the sole of my foot up with the outside of my leg. Now, some of your clients, this may already be enough of a stretch, right? See how I'm doing, I'm rotating, right? So what I'm going to do here is if I'm getting enough rotation already, or I'm already getting a stretch, I'm just going to relax here. But if I want to get more out of it, what I can do is I can press my thigh away from me like this. That's going to give me an even deeper stretch. And then if I want to go even more intense, what I can do is I can push that thigh away, and then I can thread my hands underneath and grab the leg that is supporting my other foot. And then I'm just going to pull that leg towards me. And what that does is that pulls me into hip flexion, which is further stretching that piriformis muscle. So if you got a client with really bad sciatica, or if you have a family member who always talks about how it burns and runs down their leg, that could be a really great stretch for them. You can also do one of my favorite versions of this. You can use your bed. It works really well. You can use a workout bench, and basically you're going to lay your foot up like this. You want to get it to like a right angle, and then you can go here and just sort of sit like this. This is another really great piriformis stretch. And so you just go right here, and then stretches the side of the butt. Really good ones there. Yeah, question, Irene.
Yeah, Brett, what's the main cause of sciatica?
Just what I said. It's where the muscle gets really tight, so it starts poking the nerve.
And the muscle so it's from lack of exercise and.
Yeah, it's tight muscle. Sometimes you'll see it get so tight, and they'll do like a whole surgery there. Well, they'll actually bust up some of the scar tissue manually. And sometimes, really rarely, you'll see it actually run through the piriformis muscle. Yeah, take a look at this. Sometimes you'll see the nerve, this is crazy, right? But some people will literally have their sciatic nerve, it'll run straight through it, and they're just born that way. And it doesn't cause too many problems until it suddenly starts to. That's usually like a surgery thing as well. But basically, you just want to keep that muscle as loose as possible. The looser it is, the less likely it is to pull and eventually start poking the nerve. Sometimes, I guess, sciatica could also be caused by a herniated disc. If you had a really low herniation, it could poke that sciatica as well. But generally, it's piriformis syndrome. Okay, so that's those were our hip flexors. Then we saw one hip extender here, and then we get the rest of our hip extension complex, which you're going to see the hamstring show up again, right? So these are from yesterday, but your biceps femoris long head, it performs hip extension, right? Weekly. It's not a main hip extender, right? But remember, your hamstrings are synergists with your glutes. So the biceps femoris long head, that's going to be hip extension. Your medial hamstring and semitendinosus, both of those are hip extenders as well, right? Semimembranosus and I'm missing a picture of the semitendinosus. But there's the semitendinosus. So semimembranosus, semitendinosus, both of those are also hip extenders. Oh, there's the rectus femoris. This PowerPoint's kind of weird. It's out of order. There's your rectus femoris, which was a hip flexor from earlier. The main hip extenders you've got, gluteus maximus, right, and hamstring complex. All right. Do we have any questions? So that's our motions for the hips, by the way. We've looked at flexion, we looked at extension, we looked at external rotation, internal rotation, we looked at abduction and adduction. Do you guys have any questions on those before we move up and get into the ab muscles?
Not a question, Brad, but at the end when you do the review, can you please go over, like, you know how you just went over hip extenders or the piriformis and like the hip flexor
You mean like the
extender?
movements?
Yeah, if you could just go over those.
Totally. So that's what we're going to see here at the end, right? We're going to look at like hip flexion.
Okay,
here's your
cool.
whole list. Hip extension. Here's your whole list. Yeah, we'll
Oh,
definitely. For sure. Why the heck? I keep finding these like extra pages. Okay, let's get into the abs, right? So looking at the core. So your core is another example of, you know, it is not just your abs, right? It is the entire like section attaching your to your lumbo-pelvic-hip complex. So before we dive into the actual muscles, remember you've got three main systems here. I'm not going to spend a ton of time on this, but this is going to come up again later in like other classes when we look at movements. But you have got what is called your local stabilization system. You've got your global stabilization system, and you've got your global movement system. So think of the local stabilization system as there to stabilize everything most local to you, AKA your spine. Your global stabilization system is going to stabilize everything around the outside. So that's going to stabilize like your pelvis. And then you've got your global movement system, which is like moving your arms and legs. And it's what like moves you around the globe, right? So your local stabilization system are muscles that stabilize the spine. They include, and we're going to see them in a minute, your transverse abdominis, multifidus, internal obliques, pelvic floor muscles, and diaphragm. So you want to think of this as like keeping all of your discs held in place, right? So you've got the front creating stability in the front, the back creating stability in the back, both sides creating stability on the sides, pelvic floor muscles creating stability on the bottom, and diaphragm creating stability up top. So it's like a box, right? It's like a box holding all of your Jenga blocks like in alignment so you don't have to carry them randomly wherever you're going and drop them, you know, on your way to a table. Then you get your global stabilization systems. These are muscles that move your spine, right? So they are around the outside. So if you have your transverse abdominis in the front, on top of that, you've got your rectus abdominis. And that's what we're seeing here. That's the six-pack you can see, right? So if you're working on stabilizing your spine by doing like a plank, you're working on your transverse abdominis. But if you're doing crunches, you're working on your rectus abdominis. One is stabilizing your spine, one is moving your spine. And so you've got your rectus abdominis. We had our internal obliques creating stability. We've got our external obliques moving us, right? We had our multifidus creating stability. We've got our erector spinae laying outside, moving that, right? So those are your global stabilization systems. And then you've got your global movement system, which is what attaches your pelvis to your spine. And that's actually where we're getting back into like your hip flexor complex, your hip extender complex, your abductors, your adductors. All of those are moving your pelvis, right? So we are stabilizing the spine. We are moving the spine. We are attaching and moving the spine in relation to the pelvis, okay? So first muscle we're looking at, which is kind of a weird order. I would much rather than start it with the transverse abdominis. But we are looking at the six-pack here, everybody's favorite. These are your beach muscles. Your rectus abdominis, right? So this concentrically accelerates spinal flexion, and they do a little bit of lateral flexion, and they do a little bit of rotation, but nothing to write home about. The one you want to remember is that your rectus abdominis is primarily in charge of spinal flexion, right? These are your sit-up muscles, right? These are your crunchers. So that's spinal flexion. Then you've got your external obliques, right? Your oblique muscles on the side. They are there to concentrically accelerate spinal flexion as well. So you're working your obliques a little bit when you're doing crunches, but again, that's not their main job. Their main job is lateral flexion and contralateral lateral rotation, AKA, you know, my fibers here, my fibers here are going to contract to turn me in the opposite direction, right? Contralateral rotation. So that is my external obliques. Then you've got your internal obliques. They're also going to do the same thing, but they're going to do ipsilateral rotation. So they cross over. The reason they are called oblique, right, is because they're on the outside, and they are opposite of each other, right? So they kind of create this X motion. So you've got like internal, external, internal, external, internal, external. And so like, you know, these oblique muscles contract to pull me this way, and these oblique muscles contract to pull me that way. So ipsilateral rotation, contralateral rotation, and they create stability in each other. Your internal obliques are also part of that stabilization system. They are a deep layer that is there to create stability in the spine. Rectus abdominis, that crunches, external and internal obliques, that rotates. Then you've got your transverse abdominis, arguably the most important muscle on the list. And the transverse abdominis increases your intra-abdominal pressure. So this is the only one, this is the only muscle on our list, by the way, that does not say concentrically accelerate something, because it's really not all about, it's not about moving the spine. Your transverse abdominis is not about moving your spine. It is about stabilizing your spine. It's about creating pressure so that your discs all stay in the same place. That's what's important. Transverse abdominis, creating pressure. Rectus abdominis, crunching the spine. Transverse abdominis, deep. Rectus abdominis, superficial. And then you get your diaphragm, and your diaphragm is actually more concerned with breathing, but it is creating some pressure here. I guess this also, and what you know, this is also a pressure generator similar to your TVA. Transverse abdominis, also sometimes people will call it the TVA. And this concentrically pulls the tendon inferiorly, which opens up your diaphragm and like creates your lungs, you know? So when your diaphragm sits, it sits like this naturally. And then when it contracts, it pulls inferiorly like that, which draws your lungs open. So I know, you know, you're not actually doing reps for your diaphragm traditionally when you're like doing crunches and stuff, but by continually like breathing into your stomach, you are increasing your diaphragmatic breathing, which is very good for your core musculature. So those are the way this is kind of broken down. That's basically like, we kind of have this list here. That's like the front of your spine, right? We looked at the rectus abdominis and the transverse abdominis, the internal and external obliques. So we've got the front of the body taken care of. Now we're going to look at the back of the body. So we're still going to be in the core here. But do you guys have any questions about those ab muscles first? That's the abs, right? Now we're going to look at the low back. Ab questions? Did we lose? Oh, we did lose. Oh, that's right. He has to go to work at like 10:30. No questions? All right. Let's look at the low back musculature, okay? And by the way, we got 3 more, guys. I know we've been trucking through these really fast. You guys have been doing great. You are almost done. We've almost made it through our whole list. Like I said, this is the biggest list, right? So you've got your erector spinae. So this is, I hate the order that this PowerPoint is going in. This is your low back that is in charge of spinal extension. So when you do Supermans or when you're like creating that low back arch, this is your erector spinae. So concentrically accelerates spinal extension, and it does do a little bit of spinal rotation and lateral flexion as well. So it is going to do a little bit of this, and it does it actually does a lot more of this than we thought it did. Do you guys remember how I told you about my favorite? Noelle, you're not going to remember this because I haven't talked about it. But Irene, Robert, do you remember when I was talking about training volume last module, and I talked about how Brad Schoenfeld and Brett Contreras these two kind of famous kinesiologists, they sort of were looking at training volume and how many sets per body part you should do. So they did another study together where they looked at which exercises activate your core musculature the best. And they were finding that the erector spinae does way more rotation than we thought it did, which is kind of fun. And this is only a couple of years ago. So we used to think, the erector spinae, it's mostly in charge of this, but it does do a little bit of this. It does do a little bit of like rotation on that same side. So one of the best ways you can work your erector spinae, actually, if you need to strengthen it, is not only doing like back extensions, which is great, but you can also do like a resistance band. And so you pull it here and then you pull it in and rotate away like that. And that's a really good one as well, with like a cable or a resistance band tied to the side like that. And that's a great way to get your erector spinae as well. Or sometimes you'll see people do, what's it called? It's called I think it's called a lawnmower pulls exercise. I hope it's not the row one. Yeah, see, that's not the one I'm talking about. I mean, that wouldn't be bad. She's definitely doing spinal extension there. Hyperextensions. Well, I can't really see it, but basically imagine being on the hyperextension machine, this one right here, but then also when you come up, you would pull like that. And that's a really good one. I think they're called lawnmowers. I could be wrong. Hyperextensions with rotation. There we go. That one. That's a great way to get the erector spinae. And I'm just saying that because I have a weak erector spinae, so this is something I need to work all the time. Again, posterior pelvic tilt, right? So, however, if your client has an anterior pelvic tilt, that erector spinae is definitely an overactive muscle. Again, they've got too much extension happening up top. So we need to stretch this by, well, it's in charge of spinal extension, so we need to stretch it by doing spinal flexion, right? It also does spinal rotation. So one of the best erector spinae stretches you've got, I don't have enough room to demo it for you, but if we do NASM erector spinae stretch, you can do this one right here. And that's a really good, you can see she's crossing over and then her opposite arm threads through and stretches like this. So here's a weird memory from my childhood. In 5th grade, I had a gym teacher named Mr. Babbitt, and he used to call this the Playboy stretch, which we all thought was really funny as 5th graders because we knew that Playboy was something like, we're like, oh, that's something dirty, but we didn't like really know what it meant. And then when I got older, I remember just like having this moment where like I thought of that stretch for the first time in like years, and I was like, Mr. Babbitt used to call that the Playboy in front of 5th grade. What a weirdo. That is wildly inappropriate.
So inappropriate.
Isn't that so crazy, right? I think that's so funny though. Like, he got fired for throwing a kid. Like this, and this kid was a dirtbag. Like I think this kid was such a troublemaker, and he just lost it one day, and he like picked him up by the shoulders and just like tossed him leisurely onto like a mat. But like, and he was fine, but he made a big deal out of it and he got fired. So not too surprising.
That was probably like one reason why he got fired.
Right? I know. There's probably something else crazy that happened. I always liked him. I thought Mr. Babbitt was cool. I got along with him fine. But yeah. All right. So the next one we've got, that's your erector spinae. Yeah. Oh, go ahead.
Yeah. For the erector spinae, so would that fall under dynamic stretches?
It could. Yeah, I think you could use it as both a traditional like core strength exercise, or you could use it as, you could use it as a dynamic stretch. Sure.
Okay.
That's the thing. Like sometimes your movement prep exercises double up as like dynamic stretches, There's even a note about that. Look at your look at page 382, I think, and you'll know. Yeah, maybe 382. Take a look at look at the power table, and you'll notice there's an asterisk next to core, balance, and reactive, and it will say like this section is optional because a lot of times you will have done your core, balance, and reactive as part of your dynamic stretches, because they'll often look so similar. But yeah, so that your erector spinae, you could do like Superman's and call that a dynamic stretch. But you could also just call that a core strength level exercise. All right, next one we got is your quadratus lumborum. This is your QL. And so this is attached from your bottom rib to your pelvic, the bottom part of your L5 there. So that's your lumbar spine. But then it also attaches to your pelvis. And so this is a low back muscle right back here. It's a big, thick one. And when you see somebody who has like an asymmetric shift, so like my left QL, because my left pelvis has been acting up lately, is overactive. This can also cause that lateral scoliosis move, right? So your QL is in charge of this, right? It is in charge of shifting this way. And you'll see somebody sometimes who has like an overactive QL on one side and an underactive on the other. They'll do this weird, they call it a Trendelenburg walk or a Trendelenburg gait. And it basically looks like sexy hips. And you'll see somebody who will walk and you can tell they have a scoliosis. They'll have a messed up SI joint because they'll walk kind of like this. And it looks like they're doing this kind of sexy walk, right? Like, da-na-na. You know, no. But like that is totally overactive QL muscles. And so basically their core is not activating the way it's supposed to. And so these muscles that tilt us sideways, this is why you've heard me say this before, do not do that stupid dumbbell side raise exercise. All that's doing is strengthening your QL and eventually you're just gonna pull your sacrum out of place. Dumb exercise. If you wanna do something similar to that, do a farmer's carry. That's better. Then we got your multifidus. Your multifidus is going to also perform a little bit of spinal extension. So it is similar to your rector spinae, but these are technically individual muscles. This is technically your multifidi, but sometimes you'll just hear people refer to it as the multifidus. It's like one muscle, but like if you look at it, you can see each of these is like an individual little fiber, and they're there to create spinal stability. Okay. So if you look at like little muscles like your multifidi, when you look at it, all these little tiny intrinsic muscles there. And you will also sometimes see your transverso spinalis muscles, which are also going to be in that small section there. And they are also little tiny intrinsic ones. That's a great picture. See all those little tiny individual muscles, and they're there to create stability in your low back. Again, the way you're going to strengthen these is by a lack of movement, not by doing massive amounts of movement. So many of our clients have spent so much time doing crunches and sit-ups that they're not actually strengthening their core, they're strengthening their abs, right? And that's one thing we need to kind of have perspective on all the time. We got to remember that your core is all of this. So how do we create stability? Well, we do things like balance exercises, right? Where we stand on one leg and we do like a single leg lift and chop, right? You're squeezing and you're focusing on not moving your spine. That creates that spinal stability. And the last muscle, which I didn't put in the notes here because we're definitely going to see it when we get to the shoulder day, is your latissimus dorsi. And this does have a little bit to do with your low back because of this fascia down here. That's your thoracolumbar fascia. So this is mostly in charge of shoulder extension, shoulder adduction, and shoulder internal rotation, but it does resist spinal flexion because it does do a little bit of spinal extension. it can cause a little bit of this motion to occur. So it kind of works with your low back there by pulling on the top part of your pelvis. So again, if you have a client with an anterior pelvic tilt, it could be because they have tight latissimus dorsi muscles. All right, questions about the low back? Well, guys, you got through all the muscles. Let's look at them again from two more perspectives. Let's look at the movements, then let's look at the agonists. So the movements we got hip flexion, right? We got hip extension. So that is, you know, decreasing the angle here. That's increasing the angle here, right? We've got hip abduction. That's abducting your leg away from your midline, right? Your leg's being abducted by aliens. Or you are adding it back to your midline, right? So abduction, adduction. Then we've got external rotation, rotating away from the midline. And internal, rotation, rotating toward the midline. Then you've got your special pelvic movements. You've got an anterior pelvic rotation, which is rotating this way. And you've got a posterior pelvic rotation, which is rotating this way. That's my big problem. And then you got the lateral, right? Lateral pelvic rotation going side to side. What the heck is this video? Did I put a link in here back in the day? Oh, I forgot that I put this in here as a joke. Remember the old Conan O'Brien? I think he might still do it, but he does the lateral pelvic rotation. the weird like pelvic strings thing they did during his show. That's so funny. There you go. That's pelvic rotation. I should take that out of there. That's so stupid. So that's your right left pelvic rotation. And then there is also like transverse rotation that can occur as well. Sometimes you'll see like rotary movement forwards and backwards. So she's like dropping her right back and her left forward. Then there's spinal flexion and there's spinal extension going the opposite direction. And finally, we've got spinal rotation. Actually, no, there's two more. We got spinal rotation, that's left or right. Oh, never mind. We already did lateral flexion. So that is all of our movements that we've talked about. Let's go through the agonists for each. So our hip flexor list, right? That is going to be your rectus femoris, right? So that is in charge of hip flexion. So, you know, kicking your leg up like that. That's the rectus femoris. It's going to run from here down to the front of your tibia. You've got your iliopsoas, that's your iliacus and your psoas muscles. So there's your psoas there, and there's your iliacus on the inside ridge there, right? Then you've got your tensor fasciae latae here on the outside. That's your TFL. It becomes your IT band as it continues running down. And you've got your sartorius, which actually they're not showing. Yeah, they're kind of showing it. They cut it in half because it's so long. But your sartorius is going to run from all the way up here, across the thigh, and insert onto the tibia down here. So that's your sartorius. So that's these are all of the agonists for hip flexion. Then all of your agonists for hip extension. The main one, the star of the show, right? That's your gluteus maximus. So this big butt muscle, right? Then you have got your biceps femoris long head. So that's the lateral hamstring right here. That is going to assist with hip extension. And then you've got your semimembranosus and your semitendinosus in here in the medial part of the hamstring. That is assisting in hip extension. So when you get a client who has too much hip flexion, we need to stretch these out, and they don't have enough hip extension, they need to strengthen these. So if they have an anterior pelvic tilt, stretch, strengthen. Lots of glute bridges, lots of kneeling hip flexor stretches. Yeah, what's up, Irene?
Yeah, for the biceps femoris, we don't need to know the short head of it.
You do, you definitely do. But that, remember, so your short head doesn't run to the hip. It only runs from the femur to the knee. So the short head is only in charge of knee extension and internal rotation of the knee. But these are hip muscles. Yeah, good question. Really good question. But yeah, that's the difference between the long head and the short head. The short head, because it doesn't attach to the hip, doesn't do anything to the hip. That's a great question though, because that's confusing. Then you've got abduction and adduction. The abductor list is going to be your gluteus medius, right? And your gluteus minimus kind of the TFL, but really, and yeah, like all these are kind ofs. We really are just like not working on these. The big one is this one, just like, you know, bold, italic, underline, red, you know, this one, and maybe those other ones. So it's really the hip abductor is really the gluteus medius there. But you will see a little bit from those other guys. Now your hip adductor complex, that is where we are going to see the adductor complex. That's your adductor magnus, both posterior and anterior. Your adductor longus, your adductor brevis, that pectineus, that little tiny short one, that's right in here. And then the gracilis, which is that long, skinny one that runs all the way from the groin to the inner part of your tibia there. But really, the big ones we're looking at, the prime ones that you really do want to be super familiar with, adductor magnus and adductor longus / brevis. Most of the time, though, to be honest, NASM will just call it your adductors. They'll just say like adductors in general, which is a little lazy, but it's not inaccurate. I mean, they are mostly in charge of adduction. So there's your gracilis, right? And then your adductors are kind of underneath all those. By the way, your gracilis is the one you can feel. If you actually feel along your adductor, sometimes you'll feel this little thin cord, and it feels really tight compared to like some of the soft muscles that are in there. That's the gracilis that you're feeling. Then we've got a question about the abduction adduction agonists. You guys good on those? Okay. Let's look at the rotation, right? So we're looking at hip internal rotation versus hip external rotation. So your agonists for internal rotation are, again, all your adductors, right? They're back. Same thing with your pectineus and gracilis, right? So the same muscles that did all the adduction are also the same muscles that do internal rotation, which again, we go back to knees caving in. We know that's adduction and internal rotation. So we know the adductors are overactive. But we are going to see, I flipped the slides. I was like, what happened here? What am I looking at? Sorry, I moved the slides too quickly. Here's the hip internal rotators there. So we're going to see that adductors, right? The gracilis, the pectineus. But then for hip internal rotation, you are going to see the medius anterior fibers. But again, don't think of your gluteus medius as an internal rotator. Think of it as an external rotator, because the anterior fibers are really much more part of that glute minimus. There really is a small distinction between those two. It's just they share a common attachment site. So your gluteus minimus, and then the biggest hip internal rotator that's a big bad guy, your tensor fasciae latae. So, you know, these muscles here are the ones that you really do want to get super familiar with as internal rotators. External rotators, the main one here, gluteus maximus and gluteus medius, right? Those are the real external rotators. Again, sure, like the adductor magnus posterior does a little bit, right? But primarily it's an adductor muscle. Yeah, your psoas do a little, but again, they're primarily hip flexors. So the big ones I want you to know, gluteus medius and gluteus maximus, but they do a little bit of that external rotation of the hip. Then we get into the abs. Oh, and then there's your anterior pelvic rotation. So that's not in your notes, but here is that anterior rotation, which is going to be tight hip flexors and tight low back muscles. Those are all the agonists for this. So your agonist for anterior rotation, rectus femoris, right? Because it's a knee extender, but it's primarily a hip flexor. Psoas, sartorius, TFL, tensor fasciae latae, and erector spinae. So all of the muscles pulling down on the front of the hip and all the muscles pulling up on the back of the pelvis. Posterior rotation, exact opposite. You're going to see the overactive muscles be your hamstrings. So that's pulling down in the back. Overactive muscles being your glutes. Overactive muscles being your rectus abdominis. So those are your cruncher muscles. So that's pulling up on the pelvis in the front and down on the pelvis in the back. And you're also going to see the external obliques here as well. Okay, lumbar flexion, so crunching, right? Bending the spine forward. Those are going to be your abs, right? That's your rectus abdominis and your external obliques and the internal obliques, really just obliques. But rectus abdominis and obliques, both those do flexion. Lumbar extension, pulling your spine upwards, that's your low back. That's your erector spinae and your multifidus, right? So pulling up in the, pulling back in the back. Then you've got lumbar lateral flexion. So that is the side to side motion, right? And so that's going to be your external obliques and internal obliques again. Your rectus abdominis helps a little bit, but the big one here, the main one, is your quadratus lumborum, right? Again, attaching to the side of your spine to the top of your pelvis, right? So when it squeezes you downwards this way. Again, don't do that stupid dumbbell side raise. Nobody needs to strengthen their QL. Unless, you know what, unless you have a lateral tilt. If you're like this, okay, then you can do some this way, but don't do them both ways. If you got a scoliosis, do one side. And then we got lumbar rotation, right? So that rotation is in both directions. So you've got your rectus abdominis helping there. You get your obliques helping there. You got your erector spinae helping there. Your entire core musculature is in charge of helping you rotate. The big ones that we kind of know it for, though, are the obliques and the erector spinae, right? They're doing ipsilateral and contralateral rotation. Whew. Guys, you survived the largest PowerPoint and the most technical and a whole bunch of labeling. How do you guys feel?
I'm trying to like everything you just talked about. I'm waiting for it to grow on me.
It's honestly, it's tough. It's why we do these recordings. Honestly, it makes more sense the more you kind of practice it when you start like thinking about like your motions, right? You think of like, don't think of your squat, think of it as hip extension. You know, think of like a side shuffle as hip abduction. You know, think of your movements, and then honestly, the muscles kind of come naturally. They sort of fall into place. And you look at like where they attach and stuff, it starts to make sense. But it all, Irene, it's all just a language. It all comes with practice, you know? The more you speak it, the better you are at it.
For sure. I'm so grateful for YouTube.
I know, right? Good Lord.
Refer back. Yeah.
Yeah.
Cool.
All right, guys. Noelle, do you have any questions? Robert, any questions?
Oh.
You're like, nah, man, my brain's goo. Let's just get out of here. All right. Well, you get the whole weekend to decompress. Get your homeworks done if you haven't, and relax. Take a breather.
I'm gonna go do some Wim Hof breathing exercise right now.
There you go. Love it.
Thanks, Brad. Have a kick-ass weekend.
You too. Do something fun.
I will.
I'll see you guys on Monday.
Cool.
All right, you guys have a good day.
You too, man. See ya. Robert, you made it all the way at 10:36.
Yeah, I'm in the car right now.
Are you? Awesome. All right. Well, let's get you out of here. All right. See you guys.